edukimit në vazhdim, ku marrin pjesë duke sjellë përvojën e tyre, duke shpërndar përvojë me kolegët dhe duke sjellë studime të nivelit shkencor të krahasueshme me kolegët anë mbarë në Evropës edhe gjithë botës. Merit padyshim e një drejtimi të tillë, siç e thash, dukshëm, profesional të ndryshëm nga çka ndodhur më herët, po patjetër që merit edhe gjithë secilit prej jush që shikoni veten në këto nivele dhe në këto kushte ku keni mundësinë të tregoni që dini jo vetëm të shërbeni në praktikën tuaj të përditshme njerëzve në nevojë, por edhe të referoni siç duhet, të përgatisni studime shkencore dhe t'i ndani këto përvoja me njëri tjetrin. Pra komplimentet e mia gjithëve. Së dyti, doja të shpenzoja 2 fjalë për këtë shërbimin e fizioterapisë të Spitalit të Traumës. Unë ka pak kohë që jam këtu drejtuese e Spitalit, por kam gjetur tek fizioterapia një ekip të shkëlqyer me profesionistë, drejtuar nga Drejtoreshe Manushaqja me profesionalizëm dhe kam ndjekur rrugtimin e tyre, kam parë që her pas here kërkojnë të jenë, të bëjnë më përpara në profesion dhe në shkenca, gjithmonë ka patur nga ata që përveç se janë të dalluar në punën e përditshme, profesor, angazhohen në universitete brenda dhe jashtë vendit, po e kanë shtrirë atë fushën e jetës së tyre profesionale, jo vetëm në atë misionin e këtij spitali që e ka edhe përjedhoj edhe ky shërbim, pra të trajtimit të pacientit të traumës, por trajtojnë edhe ambulatorisht pacient që vinë me patologji nga më të ndryshmet pa bërë dallim, dhe në rastin në fjalë pra për skolioza trajtojnë dhe fëmijë me shumë sukses dhe gjithnjë më shumë ne po shohim fëmijë që vinë të marrin trajtimin e tyre dhe ndihmën e tyre pranë shërbimit tonë të fizioterapisë. Në fund, duke mos dashur të zgjatem, sepse koha e këtij webinari duhet jetë e juaja dhe duhet jetë në shërbim të shkëmbimit të këtyre përvojave, unë e mbyll duke uruar suksese të gjithë pjesëmarrësve. E sigurt që rezultatet e këtij aktiviteti shkencor, si për çdo aktivitet tjetër shkencor me nivel që ne organizojmë edhe përcjellim, do të duken në punën tuaj nesër të përditshme, sepse do t'i vini në zbatim ato që do mësoni dhe do shkëmbeni përvojat tuaja duke i vënë në zbatim përvojat e njëri tjetrit në mënyrë që të eliminoni edhe ato gabime apo pasaktësi dhe në mënyrë që puna juaj e përditshme të jetë një sukses i vazhdueshëm gjithnjë në rritje. Punë të mbarë, suksese, gjithë të mirat edhe punime të mbara këtij webinari.
Shumë faleminderit doktoreshe Edlira, ju falenderojmë shumë edhe për mbështetjen edhe për inkurajimin tuaj ndaj profesionistëve të fizioterapisë. Ishte vërtet një kënaqësi. Pa humbur kohë, unë dua t'ja jap fjalën zonjës Blerina Duka, Presidente e Urdhrit të Infermierit të Shqipërisë, për një fjalim përshëndetës nga ana e saj. Zonja Duka.
Përshëndetje. Faleminderit gjithë pjesëmarrësve që kanë bërë të mundur të lidhen në këtë webinar sot. Fjalët të cilët doktoreshe Edlira tha, mua më bën të ndihesha pak në siklet, sepse unë vetëm bëj punën si drejtuese, por kërkoj gjithmonë e më shumë që profesionistët të jenë sa më shumë të dëgjuar, të jenë sa më shumë të updetuar me të rejat e shkencës dhe pse jo, pjesëmarrja e tyre në këtë webinar apo edhe në aktivitetet të tjera do të ndihmonte si gjithmonë, siç e kemi thënë, në shërbim të popullatës. Unë të falenderoj Mei për këtë iniciativë dhe për këtë punë që ke marrë për të na organizuar sot. Gjithashtu do të falenderoja edhe Perlin, edhe Silvion për mundësinë e krijimit të këtij aktiviteti. Të gjithë ne e dimë që muaji qershor është muaji i skoliozës dhe për këtë arsye ne ndërtuam këtë webinar me qasjen multidisciplinare ndaj skoliozës dhe trajtimin konservativ. Unë mendoj që gjithë ju, së bashku si që jeni sot, me këto dije që keni marrë nëpër universitete, por edhe me ato mendime që do të ndani sot, do të arrini që të përvetësoni më mirë dijet dhe t'i shërbeni sa më mirë atyre personave të cilët kanë nevojë për këtë trajtim sa më dinjitoz dhe sa më profesional. Unë personalisht edhe vetë kam ndjekur disa kurse fizioterapie dhe shikoj një ndryshim të madh nga mënyra se si e ushtroni ju sot profesionin dhe nga mënyra se si është ushtruar kohë më përpara. Dhe do të doja ose do ta kisha si një angazhim personal që jo pse çdo muaj ne mund të bëjmë ndonjë aktivitet të tillë, sigurisht duke ndërtojmë një pyetësor që të shikojmë ku i kemi ato gepet apo ku i kemi ato problematikat më të shumta dhe ta ndërmarrim një si hap që secili nga ju të thotë që shiko, unë kam këtë mundësi, mund të ndërtojmë këtë bashkë komunikim me profesionistët. Dhe unë patjetër që në dispozicion dhe me gjithë personat që punojnë në pranë zyrave të Urdhrit, me gjithë kolegët që janë antar të Urdhrit, por edhe me kolegët tanë që janë në komunitetin evropian, të ndërtoni muaj për muaj ndonjë aktivitet të tillë i cili do t'i shërbente profesionistëve. Edhe një herë, unë duke mos dashur t'ju marr minutat dhe duke lënë në dispozicion të profesionistëve, ju uroj punime të mbara në këtë webinar dhe gjithashtu do dëshiroja shumë që të kishim një feedback pozitiv edhe për aktivitetet të tjera. Doktoreshe Edlira, të falenderoj për mundësinë, për kolegët dhe gjithashtu dhe ty Mejt falenderoj për mundësinë. Suksese të gjithëve.
Faleminderit juve.
Shumë faleminderit, zonja Duka. Jemi të sigurt që Urdhri Infermierit të Shqipërisë do vazhdoj të mbështesi profesionistët e fizioterapisë në vazhdim. Sto ngelet me kaq. Okej. Atëherë, siç shumica prej jush janë informuar edhe me email në programin e eventit, do të fillojmë pa humbur kohë me temën e parë dhe do të kem kënaqësinë që të jap fjalën mjekes fiziatre, doktoresh Ermira Ziçishti, për temën e parë të webinarit të sotëm, trajtimi konservativ i skoliozave ndërrite në QSUT. Zonja Ziçishti.
Që u bëm pjesë e këtij webinari, u vlerësoj shumë para folësit dhe shpresoj që të ardhmen këtë lloj pjesë e jetës tonë të përditshme në mënyrë që të shkëmbejmë eksperjenca dhe të ecim përpara gjithmonë në shërbim të pacientëve. Si përfaqësuese që të Spitalore Universitare në Urdhri, ashtu si në përgjithësi, po veçanërisht të skoliozave, dhe këto ka qenë në qendër të vëmendjes tonë gjatë gjithë eksperiencës dhe teorisë së punës tonë. Ajo që unë dua të aktoj sot dhe të them për muajin të trajtimit dhe të parandalimit të skoliozës është që natyrisht ndër vite ne kemi pasur shumë pacientë dhe natyrisht që trajtimi i tyre ka ndryshuar ndër vite. Qendra Spitalore Universitare të shërbimit fizioterapisë ka një eksperiencë goxha të madhe në këtë drejtim, por ajo që unë dua të citoj është që vitet e fundit skolioza ka qenë gjithmonë në qendër të vëmendjes dhe fizioterapistë të veçantë kanë një mikrospecialitet në trajtimin e këtij problemi shumë të rëndësishëm. Me këtë dua të them që sot ne jemi në avangardë të trajtimit të këtij problemi, duke qenë se fizioterapistët tonë janë të trajnuar dhe të certifikuar në trajtimet më bashkëkohore të skoliozës dhe kjo bën që ne të jemi njësoj si gjithë Evropa dhe gjithë bota në trajtimin e këtij problemi, i cili është, siç e cituat dhe ju, një problem afatgjat që fillon dhe mbaron ndër vite, duke i parë këta pacientë që në fillimet e tyre, ne kemi diskutuar dhe më përpara që mosha e fillimit të skoliozës është ulur, preket më shumë femrat, sesa meshkujt. Çdo gjë duhet filluar nga profilaksia. Me një fjalë, ne duhet të ndërgjegjësojmë prindrit, fizioterapistët, mësuesit të gjithë që nëse patologjik ne e kapim në hapat e para, atëherë dhe suksesi I trajtimit do jetë më i madh. Dihet që skolioza, siç e thash pak përpara, është një problem që vazhdon në vite, kështu që edhe puna jonë është shumë e madhe, nuk mjafton me një vizitë, me një vit, po ajo do vazhdojë me vite të tëra. Duke qenë se fizioterapistët tanë janë specializuar me metodat bashkëkohore, unë shpresoj që ky webinar me këtë shkëmbim eksperiencë do jetë një sukses shumë i madh që të gjithë ne të sherim eksperjencat tona në mënyrë që ta trajtojmë sa më mirë këtë patologji që për fat keq është gjithmonë në rritje dhe ta ndalojmë dhe ta trajtojmë me shumë sukses. Faleminderit edhe një herë që na keni bërë pjesë të këtij webinari dhe ju uroj suksese në ditën e sotme.
Shumë faleminderit doktoresh. Ishte kënaqësi t'ju kishim pjesë të panelit të sotshëm. Edhe mezi presim t'ju kemi dhe në bashkëpunime të mëtejshme, ju edhe ekipin tuaj. Ishte kënaqësi. Okej, do të vazhdojmë me programin, do të vazhdojmë me një folës ndërkombëtar tani. Kam kënaqësinë t'jap fjalën zotit Rafael Hervas, I cili do të trajtojë temën e tij Treatment with corset for scoliosis, trajtimi me korse për skoliozin, për skoliozën. Now I would like to give the word to Mr. Rafael Hervas, a CPO and an orthotist with the subject treatment with corset for scoliosis. Mr. Hervas, it's a pleasure having you today.
Hello, good afternoon. Thank you so much to give me the opportunity to share my experience with the scoliosis treatment. I didn't understand nothing you was talking because I cannot talk your language, but I agree with everything you talked, so it was perfect. So let's start with my presentation. I will share my screen. Can you see my screen?
Yes.
Okay. So let me start. Okay, so there are many types of corsets, but today I am going to talk to you about my experience with the Rigaud-Chenot type corset in combination, of course, with the physiotherapy. In this presentation, I decide to put a long text because if you don't understand my English, it should be easier for you to read the screens. Okay. To start, I need to talk about the importance to work as a multidisciplinary team. This is the most important thing from my point of view. The most important person is, of course, the patient. And after, we need to create a very good team between the physiotherapist, the rehabilitator, doctor, the family, and the orthotics. The importance of the psychology. From my years of experience, I have realized that the psychology is the most important thing in the treatment of scoliosis with corsets. Not all protocols are the most appropriate in certain cases because, you know, we need to adjust to every patient. Sticking to them can be a big mistake since we must always adapt to each step. Now let's talk about the patient assessment. When we use the Rigaud-Chenot technique, we need to evaluate the morphology of the patients. This is the first and most important thing, to analyze the morphology of the patients in their natural scoliotic posture. It is important to remember that when we take in photos, in addition to the fact that these photos must have a very good perspective, the patient's posture must be their natural one with the scoliotic attitude that they present. Sometimes happen that when you are taking pictures, they rectify the natural posture, and this is a wrong way to start to evaluate it. So when we have the patients, we can understand what we have in front of us. After this, it's important also to doing some kinds of tests to assess the spinal rotation, the degree flexibility, etc., etc., etc. Once we have clear the type of curve pattern we have in front of us, is when we will take a look about the rigor classifications to understand which type of pattern we have in front of us. In my case, I use the CAD/CAM technology to make these designs. So once I scan the patients, I import in the software the scan, the picture, and X-ray to start to rectify or design my corsets. Some features of the regjistrime technique that set it apart from the rest. When we talk about it, we are talking about 3D brace that should combine the torsional forces as a regional rotation, caudal and cranial counter-rotation forces, the 3-point system giving frontal plane alignment, proper sagittal plane profile balance, and of course, proper shape and orientation of the contact areas, providing a dynamic mechanisms to fight against the lordotiltation. Some features of the regjistrime technique that set up apart from the rest, how we could convert the corset into a dynamic one. In these pictures, you can see the transversal sections in the dorsal apex, right? So in red color, you could see the patient with the normal posture. The blue one should be the patient in brace, and the green one is the cross-section of the corset. It's really, really important to apply big expansion areas to convert it, the corset, as a dynamic corset. It's really important to train the children to achieve a good breathing. Let's see the video where you can understand that, of course, we apply a big expansion, and look what's happened when the children start to breathe. It's really important to create a big expansion to let the corset works as a dynamic corset. And also, of course, you know that we need to use the corset for a long time, at least for a year, right? So you can see that how when the boys are breathing, we create a space to give a space to the body to go in the good place. Here you can see other videos where you can see in a real case how it works, the expansion areas. With each inspiration, the pressure forces increase, improving the control of the spine. It is very good in this case as well to palpate the spinous processes when doing this breathing exercise. If the corset is well made, we can see that when we are touching the spinal processes, with each inspiration, the spine corrects more. The first and most important thing should always be alignment in the frontal and sagittal planes. Sometimes we can get it at the beginning, but in other cases, we need to go little by little to get it during the treatment. In this case, you can see one case where the alignment in the frontal plane according sacral lane is okay. It's really important to train the patients to correct the alignment. On many occasions, they unconsciously escape pressure, and this worsens the alignment in the frontal plane. The physiotherapy helps us a lot to control these involuntary movements by patients. In those cases in which the patient does not receive physiotherapy, we must be the ones who train them to correct the posture and thus improve the alignment in the frontal plane. It is also very important to train them to rise their shoulder when we need to have a very high support at the axilla. Logically, they will notice numbness on their left arm, so they must learn to rise it and repeat the process every minute because they will forget. By repeating this movement frequently between 10-15 days, we will solve the problem. When we need to push the axilla support pad higher, we should never lower because we will have some problems in cases when we have the apex at the T3 and T4. Let's see some samples with when we are talking about it. On the left picture, you can see that the girl is reacting to the lumbar part pressure, and he destroyed the align in the frontal plane. I like to put a mark on the central, on the midpoint. Yes. We mark a point in the circle, in the midpoint of the buttocks, and at the same time, we identify the spinal processes of the 7th cervical. We adjust the laser on the bottom part to understand how much we should rectify. If we train the girl to correct it, we can get, this is the same girl, that if we train them, they can get it. Okay, this is other example when we use a notum pelvis. The pressure that we apply on the lumbar is not comfortable for them, so they react tilting the body to the left. So we need to train as well that it's not possible to do it, and they need to rectify. Okay. So if we work as a multidisciplinary team and all of us use the same speech, we guarantee very good results without treatment. Let's see some samples. In this case, it was not the best way. It was a chirurgical cases. And also in this case, these patients came from 1,000 kilometers from our orthopedic clinic. The fabrication, texting, and X-ray was done on the same day. I don't agree about it, but the doctor pushed to do it. It is not appropriate since we prepare to leave an adaptation period of a month and then do the X-ray. But we had no other choice. Taking in account the characteristics of the patients, that the calves were quite structured and that it was the first day of the corset, the result was not so bad. We will carry out regular reviews and we are convinced that little by little we will improve until we achieve the best possible control. This case is a 9-year-old patient. It was the first corset for the patient. Also, this is crazy here in Brazil. The patient was living far away. We did everything at the same day, taking in account that this is a young patient, that it's going to be his first corset, and that we have many years ahead of us. We did not want very aggressive during the first day. The result was not so bad, and we are sure that as we carry out the period revision, the control will be very good. It is important to remember that we must adapt to the patients. This is the most important thing, using the psychology to go little by little to get the best result as possible. If we try to go fast without counting on the patients, they may reject the corset and the result will be a failure. This is another case where we can do the things better because the radiological test was done when we advised after a month. We was doing during the first days a small adjustment, talking with the patients and so on. And finally, once we was sure that the control was good, it when we decide to take the X-ray. Again, when we talk about the psychology, when you have a difficult patient and you wait to take the X-ray, you do your job as best as possible, and you show the 2 X-ray, they can understand that it's okay to use the corsets. This is other case. Again, the radiological test was done after a month. After the adjustment and delivery the corset, we saw that the girl had difficulty tolerating the right axillary contact support. So we decided to increase little by little the axilla height. We adjust the corset a little and instructed the patient to increase the pressure of the velcros until reaching the marks that we mark on the velcros. We did our first review 2 weeks later and slightly increases the right axillary support. After a month of adaptation, we saw that the patient managed to tighten the velcros up to establish the objective. She even passed the objective. We palpated the spinous processes and found that everything was good, but we had a big mistake from our side, because as you can see, the neck was tilting to the left. So when we saw this, we decided to lower the right armpit support. Here we can see a case of a girl that we make the brace in September 2022. You can see the X-ray. After 3 months wearing the corset, taking the picture, you can see that we improve very good the frontal align. And in this case, we decide don't take the X-ray to postpone for later months. Sometimes it is not necessary, from my point of view, to take X-ray every frequently, you know what I mean? Another case, you can see that this case, we have a difficult case because we have 2 proximal curves, but we start to do our job. Of course, I feel that every time we need to modify the corset and train to the patients to improve little by little the control. This is another case, a type of B1. It is the same. We start to feed the corset, talking, using the psychology with the girl, and pushing to tight a little bit more the forces of the Velcro. And once we see that everything was okay, we did the X-ray. In this case, again, we need to elevate a little bit the axilla, the left axilla, to control the proximal part of the spine. This is another case. This is probably it was the worst case, because the reaction of the girl was really bad. She had a big problems in terms of psychology. So we spent 70 days until we decide to take the X-ray. She was crying every day. But after 70 days, when everything was okay, we decided to take the X-ray. And when we saw the both X-rays, the girl stopped to cry and start to collaborate as we want. This is other cases. When we have both cases, we need to control kyphosis and scoliosis. This is other cases. It's not scoliosis, but it's nice to show with you. You can see the X-ray, you can see the lateral picture, and the result was really good. Another cases, when we need to treat scoliosis and kyphosis, I start to move faster the slide because I have not a lot of time. This is a complex case that the doctor forced me to make a corset after surgery. I have fear because I don't want to have any type of problems with the arthrodesis screw. But at the end, we go to rectify the kyphosis. This is some samples when we need to make a corset for a little ones. It's interesting to define a very good protocols to take pictures and scan using different techniques to make the best corset as possible. If you have some cases like this and you want my advice, don't hesitate to contact me. This is a case of old baby for 14 months. In this case, we decide to stop the progression. The doctor has fear of reducing the respiratory capacity, so we decide to make a V-valve corset. This is not the best corset for me, but at the end, you can see that we stop after a month, we stop the progression and we start to rectify a little bit. Let's work as a team. This is the most important thing. Let's use the psychology. Remember that we should adjust to each patient. And if you want to collaborate with me, don't hesitate to send me an email or write a WhatsApp or Telegram message. And for me, would be a pleasure to collaborate with all of you. Thank you so much for your attention, and we keep in touch. Bye-bye.
Thank you so much, Mr. Hervas. It was a real pleasure having you on our panel today and looking forward to future collaborations. Why not?
Thank you so much.
Okay. Mirë, do të vazhdojmë tani me një temë nga doktoresh Sabrina Donzeli, presidente e SOSORT. Tema e zonjës Donzeli do të jetë e regjistruar me video. Titulli i temës së saj është Natural History of Scoliosis and Guidelines, pra historia e skoliozës edhe guideline-et apo protokollet e trajtimit. Përpara se të mund të shihni të gjithë në ekranet tuaja videon, dua t'ju rikujtoj për dy gjëra. Së pari, nëse dikush ka pyetje, të mund t'i mbaj shënim që të mund t'i bëjmë në fund të gjithë programit edhe të gjitha temave. Zonja Donzeli do të jetë në linjë gjatë kohës të pyetjeve dhe të përgjigjeve, sa për t'ju informuar. Gjithashtu, ju lutem nëse keni hyrë në platformën Zoom me emërtime të tjera dhe jo me emrat tuaj të plot, ju lutem të mund t'i kontrolloni edhe t'i vendosni emrat tuaj të plot, për shkak se do të na duhet në fund për të nxjerrë listë prezencën edhe për certifikatat në mënyrë që t'i merrni gjithë secili prej jush. Mirë, atëherë në rregull, pa humbur kohë, vazhdojmë me videon e doktoresh Sabrina Donzeli.
Me mund ta më lejoshit të bëj share screen të Do you see my screen?
Po.
Hello, everyone. It is with great pleasure that I'm presenting today about scoliosis natural history. So we know very well we have many different forms of scoliosis, but is the history, the natural history, different between these forms? Part of this classification is a chronological classification depending on the moment in time when scoliosis diagnosis is happening. So if it's happening before age 9, we call it early onset. If it's happening from 10 until the end of growth, we call it adolescent, and adults, of course, for adults. Secondary forms include congenital, neurological, and iatrogenic form, while most of the scoliosis form, as you may know, is idiopathic because we don't know what is the cause. So there could be some little differences in the natural history between all these forms. So this lecture will go through the differences on natural history on these different forms. So in general terms, when you search in the literature, you will find that secondary form, including neurological, congenital, iatrogenic, tend to be defined as higher risk forms, but also early onset forms, so infantile, happening between age 0 to 3, and juvenile scoliosis between 4 and 9 years of age, are considered a higher risk form. So what is the main difference between juvenile and infantile idiopathic scoliosis, and is there any difference in the natural history? So, of course, early onset is including, as I already told you, both juvenile and infantile scoliosis. And what are the differences also between these early onset forms and adolescent form? So first of all, in infantile scoliosis, left thoracic curve are more frequent, while you may know in idiopathic adolescent forms, right thoracic curve are more frequent. We have higher rate of males with scoliosis, while females prevalence raise while we move towards adolescent forms, and probably they have worse prognosis. The reason why I put a question marks is that in most of the studies dedicated to infantile scoliosis, secondary and idiopathic form are mixed up. So it could be probably that secondary form have worse prognosis, but mixing everything should give then a general worse prognosis, which probably is not true. Sometimes it's very difficult to discriminate when the patients are really young. So this is the reason why some doubts remain. So, natural history of infantile scoliosis includes self-resolving forms. We have also in adolescent forms sometimes this type of self-resolving or self-limiting in progression forms, but probably in infantile forms this is more prevalent. Otherwise, they tend to be very aggressive, so with a lot of progression over time, but there are also intermediate forms. So, of course, we know that growth and genetics are major factors influencing the risk of progression and therefore also the natural history of scoliosis. But, and you can imagine that in earlier onset form, we will have more growth and therefore in the end much more risk of progression. As you can see here, the rhythm of growth is different, and in the first year of life it's very fast, like an exponential way of increasing growth over time. Then it progressively slows down until age 2, and then at age 4 generally the growth is stabilized to have a little peak of growth between age 6 and 8, and then raise again close to puberty. One of the measurements that we have to discriminate between self-resolving form and more aggressive ones is this measure. So it has been developed by Dr. Mehta, an expert in using CAST in infantile scoliosis, and it was developed also because measuring cup angle in patients not walking, not able to stand yet, is a big challenge. So what they found is that if this the difference between these two angle X and Y, it's below 20, then we have progressive form independently on the cup angle measured. Another prognostic sign is the overlap of the rib. So if there is overlap of the rib on the vertebral body, then this means that the form will be progressive. Let's talk about juvenile scoliosis, which is regarding patients aged between 4 and 9. So here in these forms, the higher risk period is puberty, of course. Sometimes there's a peak in growth between 6 and 8 years of age, and so I would be careful in that period of time. In my experience, many times scoliosis onset is happening immediately after that peak, so probably is more frequent around age 6. So they come to diagnosis between age 6 and 8 just because there was this small peak of growth. So the natural history of juvenile scoliosis forms is that when they reach 30 degrees at puberty, 100% of the patients will become surgical. So it seems that progression can be very fast and very aggressive. 75% of those with a curve between 21 and 35 progress until surgical threshold. This study was published in 2006 and regarded non-treated patients. Then it seems that thoracic curve exposed to higher risk of progression when compared to lumbar and thoracolumbar curve. There are also studies highlighting so many similarities between juvenile and adolescent forms. So, for example, this study, which was published in 2014, we found that brace effects are not different in juvenile and adolescent forms when they reach the diagnosis later on. So we practically included adolescent with previous X-rays demonstrating that that was a juvenile form, and compared with a matched cohort of patients with a diagnosis happening during adolescence, so after age 10. So of course the criteria, the chronological criteria cannot be always precise. So sometimes we delay a diagnosis of a juvenile form, and for sure juvenile forms reaching a diagnosis later on and already in adolescent period probably tend to be less aggressive than the forms showing themselves earlier. And this is another study on infantile idiopathic scoliosis compared to secondary form. And what was found was that the idiopathic form tend to respond better to braces than secondary form, which tend to be more aggressive. So as you can see here, there was a little difference in management in secondary form, and that the winning of the brace was possible mainly in idiopathic form. So related to congenital scoliosis, here you have a definition. So is a lateral curve of the spine that is due to the presence of vertebral development anomalies that cause an imbalance in the longitudinal growth of the spine. And we can have different types of congenital scoliosis, like failure of formation and also failure of segmentation, and multiple combination of these two types. There can be sometimes associated to vertebral congenital alteration, also rib fusion, which could prevent correction, for example, with a brace. So pay attention to also to these type of congenital deformities. As you can see, the incidence is really low of this type of form. And here you have another classification. So they can be localized in the proximal thoracic curve or in the thoracic, and in the thoracolumbar or lumbar area. And you see the prevalence expressed in percentage. So the most frequent forms are at the thoracic level, both proximal or thoracic. The prognosis and natural history of congenital form is better, and so the natural history is towards a self-resolving or not very progressive curve when the localization is at the proximal thoracic level, and particularly if we find segmentation defects, while thoracolumbar and lumbar with formation defects tend to be much more aggressive. There could be also associated anomalies, neurological, renal, or cardiac, and this is why an MRI is recommended in those forms. Also, rib cage deformity in these forms, as well as in infantile and juvenile, in general terms, in the most aggressive forms, can affect the lung capacity. So we need to take care of this when considering the potential risk related to the natural history of scoliosis. So now let's talk about adulthood. What could be the risks in adulthood? There are many risk factors to be considered. First of all, back pain, progression during adulthood, lung capacity and death risk too, pregnancy, delivery risks, and affection and quality of life. So related to pain, there are multiple studies trying to explore this part. Pain incidence and amount, and the amount of pain is very similar to the general public, but there should be a faster deterioration of the joint structure compared to the general public. Another association to pain is the sagittal balance, which was found to be important to be restored in order to prevent pain. We know that sagittal profile is often compromised in scoliosis forms and should affect also adulthood. Visual analogic scale is not correlated to scoliosis and cobengo. And again, the low back pain prevalence was found to be very similar to the general population. So these studies found out that there could be a faster progression for lumbar curve compared to thoracic curve in adults. And another biggest study on adulthood, which was done studying adult subjects all over life, subjects who were never treated. And here you have the history of the curve according to the localization. So at the thoracic level, what they found was that curve below 30 degrees had no progression, while between 30 and 50, they had a progression which was on average 0.5 degrees per year. And when the curves exceeded 50 Cobb degrees, the progression was between 0.75 and 1 degree on average per year. Then for lumbar curve below 30 degree, no progression. For curves between 30 and 50, the progression was about 0.4 per year and 1 Cobb degree on average per year for curves exceeding 50 degrees. So you see the reason why the surgical indication has been set up around 50 Cobb degrees of curve. For the thoracolumbar curve is very similar. So again, the progression was about 0.5 Cobb degrees on average per year for curves until between 30 and or more than 50 degrees. So again, the same for double major curves. Curves larger than 50 Cobb degrees progressed on average 0.5 Cobbing per year. So regarding lung function, the thoracic curve seems to affect much more lung function. It's of course related to curve size, generally more frequent in smokers. And in no-smokers, lung function is affected when the curve is exceeding 100 degrees, and if there is thoracic hypokyphosis. This comes from a systematic review published in 2019, and you see again that significant impairments in lung function was found for curves exceeding 50 Cobb degrees. So pregnancy is not associated to higher risk of progression, and no higher rate of cesarean section in patients with scoliosis was found. It seems that impact on quality of life and psychosocial involvement can be affected in patients with scoliosis. Few studies explore these kind of things, and the result can be slightly different, but it seems that the cosmetic aspects play a major role in determining the affection on quality of life. So I thank you very much for your kind attention, and I'm ready to answer to any question you will have. See you soon. Bye-bye.
Okej, pasi pam edhe videon e doktoresh Doncelit, pa humbur kohë, dua t'jap fjalën profesor Darius Çaprovski me temën e tij screening shkollor për identifikimin e hershëm të skoliozës idiopatike. Professor Darius Czaprovski, welcome.
Hello, everyone.
I just presented the title of your topic, and the word is for you.
I hope you hear
Thank
me
you.
and you can see the presentation.
Yes, yes, everything is very clear.
Great. So, can I start? Okay.
Of course.
Thank you very much for the invitation. It is a great pleasure to be here and to show you the proposal of the recommendation for screening of idiopathic scoliosis. As we heard in the previous presentation, scoliosis, idiopathic scoliosis, is a three-dimensional deformity of the spine with unknown etiology. Its progression is related to age and peak high velocity. In Poland, unfortunately, we don't know what is the real epidemiology, the prevalence of idiopathic scoliosis. So, important question is why we are not able to plan and to conduct the huge epidemiological study based on universal screening programs. Of course, there are a lot of answers. First of all, there is still incorrect knowledge about idiopathic scoliosis. All the time we observe a confusion between idiopathic scoliosis and various functional postural problems. Maybe one of the reasons for this fact is insufficient number of specialists. I think about both physicians, physiotherapists, and nurses who are trained in modern diagnostics and modern treatment of idiopathic scoliosis. And another problem is that the incorrect methodology of screening programs, of existing screening programs, especially in the area of poor reliability, I think especially about poor specificity, which lead to false positive results. Therefore, the Committee for Rehabilitation, Physical Education and Social Integration of the Polish Academy of Sciences established a task force for the diagnosis and conservative treatment of idiopathic scoliosis. In the task, they were 16 members. Like you can see, there were physiotherapists, physicians, physical education teachers, and one epidemiologist. Here you can see the names of all members of the task, and I had the honor to be a chair of this team. So our main aim was to develop the recommendations for screening of idiopathic scoliosis. And before we start our work, we have created 4 questions, from our point of view, the most important questions. First of all, why to screen? The next question was how to screen, how to perform screening. The third question was who and when should be screened, and finally, who should perform screening. And we look for the answers based on the analysis of the existing current recommendation of the societies related to spinal deformities like SOSORT, like SRS or RSSD. We also verified the Polish law in respect of the health system. We also analyzed the actual literature, actual data, and finally we used Delphi technique to prepare the final recommendations. First question was why to screen. So we look for the justification for the screening, and we have created next 4 questions. The first question was, is idiopathic scoliosis a dangerous disease or not? So what can be the consequences of late detection of idiopathic scoliosis? Firstly, worsening of aesthetics. I think that all of us, we heard the questions from a child, for example, can I look better, or I'm ashamed to undress. The next consequence we observe is a back pain. Another one, decreased physical capacity and physical fitness. Of course, for children with cup angle value between 25 to 40 degrees, usually we need to apply brace. However, wearing a brace for example, 20 hours per day may lead to higher level of stress or lower quality of life. For children with severe scoliosis, we have to take into consideration surgery treatment. Of course, surgery treatment usually leads to amazing changes in the alignment of the spine and the trunk. However, from the functional point of view, we cannot to say that surgery treatment is an optimal treatment, because it will lead also to permanent stiffening of the spine and to permanent limitation of the trunk mobility. We also observe in the areas free from the stabilization, overloading. It is also the consequence, negative consequence of the surgery treatment. So the next question was, is idiopathic scoliosis a common disease? According to the literature, the idiopathic scoliosis affects about 2–3% of children. So it is an important value or not. In Poland, in typical class at school is about 30 children. That means that 1 child in each class, in each school, may be affected by idiopathic scoliosis. So it seems it is important number of children with the group of the risk of development of scoliosis. The next question was, is it possible to detect idiopathic scoliosis during screening? As we know, the main parameter for evaluation of scoliosis, idiopathic scoliosis, is a cup angle value. However, we cannot use it in screening programs because of invasive character of X-ray. On the other hand, the main clinical parameter we use is the evaluation of angle of trunk rotation using scoliometer. What is typical for this method? First of all, it is non-invasive method, is cost-effective, is fast, but what seems crucial, the method is reliable. That means it's sensitive and specific, so we can minimize the number of false negative and false positive results. Does the early detection allow to treat idiopathic scoliosis effectively? Also a very important question to justify the screening. I think that we know the BRACE study, the study by Weinstein and colleagues, and the results of this study was published in the New England Journal of Medicine. And we know the study revealed that BRACE treatment can significantly decrease the risk of progression of scoliosis. But what about physiotherapy? Society on Scoliosis, Orthopedic and Rehabilitation Treatment, that is SOSORT, established a guidelines, which part is the description of the rules for so-called specific physiotherapy. Based on these rules, we could start studies aimed at to verification the influence of physiotherapy on many aspects related to idiopathic scoliosis, like cup angle value, like angle of trunk rotation, like aesthetics, like quality of life. As a result of these studies, the studies with good quality, the societies normally related to surgery treatment, like SRS, for example, stated that bracing and scoliosis-specific exercises can decrease risk of curve progression. However, there is a very important condition. To be effective, conservative treatment, that means bracing and physiotherapy, need to be applied for mild scoliosis. Therefore, very important is early detection, that means screening of this deformity. So, do we have justification for screening? I think yes, because we can positively answer for each of these questions. So, how to screen, how to make screening to early detect of idiopathic scoliosis? First of all, it is recommended to assess asymmetry of the back performed during Adam's test, that means during trunk forward bend, and we measure during this bending angle of trunk rotation. Both starting position and movement should be performed in the standard way to increase reliability of the evaluation. For the objective evaluation of angle of trunk rotation, it is recommended to use scoliometer. And we measure angle of trunk rotation at 3 levels. The first level is between T1 and T4, that means proximal thoracic area. The next one is main thoracic, that means between T5, T12, and finally at the level of thoracolumbar or lumbar part of the spine. The next question is who and when should be screened. And we have analyzed the growth spurt of children, and based on the higher risk in the group of the girls should be screened 3 times with 1 year intervals. That means at 10, at 11, and at 12 years. In the case of girls who don't menstruate at 12 years old, the screening should be repeated in 12-month-long intervals until menarche. For boys, the screening should be performed twice with 2 years interval, that means at 12 and at 14 years. So how to interpret results? If screening revealed 8 years of 0 to 3 degrees, that means the child should be assessed in normal intervals. That means for girls, year after year, for boys with 2 years interval without additional evaluation. If angle of trunk rotation is between 4 to 6, a child should undergo to the additional, apart from the standard intervals, additional test after 3-6 months. And in the case of girls with angle of trunk rotation 7 degrees or more, we should extend diagnostics, including X-ray. And finally, the question is who should perform screening? And maybe it's a little bit different in comparison to other countries, but in Poland, the screening can be performed only by medical professionals who have competences in the evaluation of musculoskeletal system. That means, for example, pediatricians, specialists in medical rehabilitation, but also physiotherapists and nurses. But in Poland, maybe in Albania is a different situation. In Poland, screening cannot be performed by physical education teachers because they are not medical professionals. So, in conclusion, first of all, we should be aware that late diagnosis of idiopathic scoliosis may lead to important negative consequences for health, but it is possible to detect idiopathic scoliosis during screening. However, to avoid under and over diagnosis, we have to use reliable methods. That means scoliometer with cut-off 7 degrees. It is possible to effectively treat children with idiopathic scoliosis with the use of conservative methods like physiotherapy or brace, and we can decrease the risk of progression of scoliosis, and in consequence, we can decrease the need for brace or surgery. Of course, also we can improve the aesthetics and improve quality of life. And here only 2 examples of children treated using physiotherapy. Of course, we have a lot of other examples. However, a very important condition is that if you want to be effective, I think about professionals who are working with conservative treatment, the key condition is early detection of idiopathic scoliosis. If you are interested with full version of these recommendations, please write me email and I can send you the full paper. The paper is in English, so I hope it will be useful for you. So please write me and I will send you a full version of the paper. Silvio, thank you very much for the invitation. It was great pleasure to be here. I hope here is correctly. Thank you very much for the invitation. Thank you again.
You're welcome, Darius.
Thank you, Professor Zabrowski. It was such a pleasure. Thank you so much. Okej, mirë, pa humbur kohë, fjalën do t'ja jap Silvio Selfo me temën e tij, Physiotherapy Scoliosis Specific Exercise. Silvio, radha për ty. Vetëm ndiz mikrofonin.
Më dëgjon?
Po, tani është okay.
Okay. I think you see my screen.
Po.
Okay. My topic will be about physiotherapeutic scoliosis specific exercises, PSSE short by Nikos Karavidas. I would like to start my presentation by introducing the mentor of or the inventor of the PSSE short method. Nikos Karavidas is a physiotherapist from Greece. He started his education for scoliosis in 2012 in CS with Michele Romano and Stefano Negrini. In 2014, he was certified by Dr. Manuel Rigo in VTS-PTS Rigo concept. He was certified in 2015 in short best practice by Dr. Hans Rudolf Weiss. In 2018, he was certified by Axel Hennes in short ISST. And in Lyon in 2020. He gave more than 40 courses in 5 years from since 2017 to 2022. All this time, he gained his knowledge by participating in all these courses and conferences, and he gained his clinical experience. So this leads to create new concept of rehabilitation of scoliosis. So the official start of the latest advancement in scoliosis conservative treatment was in 2022. So the PSSE short method by Nikos Karavidas. To let you know more about short method history, this is original short method invented by Katarina and Krista Short a little bit more than 100 years ago. This method was in use until 2009. Until the leaders of the school decides to go by their own with different classification, with different ideas of correction. And so in 2009, we have 3 branches of short method, short ISST, Axel Hans, VTS Rigo concept, Manuel Rigo, short best practice, Hans Rudolf Weiss. And now I have to say to you that the original short method does not exist anymore. There are only short-based methods with different classifications and principles of correction. So also PSSE short method that was invented or created in 2022 is also a short-based method. PSSE short method is a program of physiotherapeutic scoliosis specific exercise working for scoliosis and kyphosis treatment. PSSE short concepts acquired by a clinical experience based on original short principles, getting also adaptation from other PSSE schools, keeping their advantages, improving their limitation, or excluding their limitation. So now in our method, we have a new curve type classification, innovative ideas for 3D correction. PSSC short method advancement in classification. Our classification is easy and accurate classification to describe all curve types just by 3 simple questions needs to be answered. Important to give proper information to the therapist on how accordingly treat their patients. Concept of overcorrection, the decision for plus and minus, is based on clinical, radiological, and prognostic criteria, and is taken from initial classification. Maximum of correction for curve types when recommended. Avoid when it is risky for creating compensation, double or balanced curve. Avoid dilemmas on how to classify, treat curve types or curve types that are balanced, thoracic and the lumbar. Avoid dilemmas on how to classify and treat curve types when pelvis is almost balanced. Avoid dilemmas on how to classify and treat curve types when you are not sure whether thoracic is structural or not. Avoid dilemmas on how to treat thoracolumbar curve types with apex T12 L1. Our education, because I think that we have a lot of physiotherapists here, is proper duration of education, not too long, not too short, 9 days to start applying the method in every type, 15 days for final certification, basic course online live by teaching on Zoom with an instructor, high quality of theoretical education. We have a clinical assessments and evaluation tools, prognosis, radiological measurement, pathomechanism of progression, etc. Unique patients evaluation form for clinical and radiological assessments. Advancement of our school in practical application. You can treat your patient precisely and safely to get the maximum effect of exercise based on their curve type. We have innovative concept for 3D connection. We have a new terminology, so described for the first time, with perfect accuracy on describing the body blocks and the concept of correction. New idea for corrective or rotational breathing. We have also a new technique for muscle activation, thoracic under traction, traction on L side, shoulder counter traction on T sides. We have new concept for activities of daily living training based on PSSC short method classification. So this is for the first time described in our method. Selective overcorrection for specific curve types. So this is also a new terminology, selective overcorrection. So I think this is the first time in all short schools that is described selective overcorrection. New exercise and different execution of already existing short exercise based on curve type classification. New idea for mobilization by therapy, combination of corrective breathing with mobilization. Special emphasis on proximal thoracic scoliosis, new concepts of correction. Special emphasis on thoracolumbar curves, ventral flat zone on L side, new idea of correction. We have also a large variety of exercise for scoliosis and kyphosis since the level 1. Just to go more in depth for idiopathic scoliosis. Scoliosis is derived from an ancient Greek word scolios, which means curved or crooked. The cause of idiopathic scoliosis has been not found yet, although the efforts to correct this deformity come from antiquity. The definition from scoliosis, SRS, Scoliosis Research Society for Scoliosis, is that scoliosis is a lateral deviation of the spine with comb angle more than 10 degrees with rotation of a known reason. For the definition of scoliosis, according to SOSORT, or Society on Scoliosis Orthopedic Rehabilitation Treatments, is that idiopathic scoliosis can be defined as a complex 3-dimensional deformity of the spines and the trunk, which appears in apparently healthy children and can progress in relation to multiple factors during any rapid period of growth or later in life. Aims of non-operative treatment of idiopathic scoliosis is that 3D treatment of deformity with stopping progression or even partially correct, improve the clinical appearance or aesthetics, train for activity of daily living, decrease the pain, improve the breathing function, also improve the quality of life. We have a lot of studies that support PSSC short. This was a study by Nikos Karavidas and his Greek group. About PSSC short specific exercise can reduce the risk for progression during the peak of growth in curves below 25 degree. It was a prospective control study. It was has participated 221 patients. This is the largest sample in published literature. And the success rate, it was no progression more than 5 degree. PSSC short group 87.5% and the control group was 25.9%. The conclusion after this study research, application of PSSC short exercise can be effective to reduce the risk of progression at the peak of growth in mild scoliosis below 25 degrees. Significant improvement of trunk rotation, body symmetry, and quality of life. Also, we have another study from Nikos Karavidas from Greece, brace and physiotherapeutic scoliosis specific exercises for adolescent idiopathic scoliosis treatment. This is a prospective study following SRS criteria. The conclusion of this study, it was that the combination of brace and PSSC short exercise can effectively treat the adolescent idiopathic scoliosis at the risky period during peak of growth. Most important prognostic factors and the compliance and embrace correction. We also have another page that it was presented this year in SOSORT about our classification, intra-rater and intra-raterability of a new adolescent idiopathic scoliosis curve type classification based on clinical, radiological, and prognostic criteria. The conclusion was that PSSC short classification show a very good intra-rater percent agreement of 0.87 and an excellent intra-rater percent agreement of 0.95. It's a very analytical and precise classification system, including different curve types and about to have a good excellence reliability. SOSORT guidelines, it was a page in 2011 and 2016. So the guidelines of SOSORT say that PSSC are the first step to treat scoliosis and to prevent the progression or bracing. PSSC based on 3D autocorrection activities of daily living, training, and stabilization of corrective posture through the patient's education. PSSC programs are designed only by certified physiotherapists. Individualization program according to the curve type patient's need and treatment phase. A multi-professional therapeutic team consisted of a doctor, orthotist, and physiotherapist is recommended. Brace students should be accompanied by specific exercises. Sports activity cannot be considered as an alternative treatment, but patients are encouraged to participate in sport for their general benefits. The term physiotherapeutic scoliosis specific exercises is to describe curve pattern specific exercises. There are three characteristics. The first one is 3D autocorrection, patient education for activity of daily living, stabilization of corrective posture. There are not just short methods that are, let's say, specific exercises, but also we have other schools like in Italy, SIAS, France, Lyon, Germany, short ISST and best practice, Spain, BSPTS, Rigo concept, Poland, Dobomet and TITS, United Kingdom, side shift, and Greece, PSSC short. So the latest advancement in scoliosis conservative treatment. This is a message from SOSORT that it was included in, it was in 2023 in Melbourne, Australia. So SOSORT does not recommend, support, partner, approve, endorse, or favor any individual clinical product, service, process, or method. To classify according to the our classification, we have to answer three questions. The first one, is there a structural thoracic curve? The second one, pelvis position relationship to the trunk. And the third one, is overcorrection allowed for the main curve? We go to the algorithm of our classification. So our classification is an algorithm. The first question is there a structural thoracic curve? If the answer is yes, we go to the second question. Pelvis position is related to the trunk in frontal plane. So the pelvis would be on the left, on the center, or on the right. So if the pelvis is on thoracic concavity, it will be 3C. If the pelvis on the thoracic convexity, it will be 4C. If the pelvis is symmetric, it will be non-3, non-4 type. If the answer of the first question is no, we go to question 1B. Is there a structural lumbar or thoracolumbar? If the answer is yes, we go to SLSTL type. Now we go to the most important question that is, let's say, the innovation in the classification and scoliosis conservative treatment. Is overcorrection allowed for the main curve? When we speak about the main curve for 3C type, we speak about thoracic. And also not 3-4 type, we speak about thoracic. For 4C and SLSTL type, we speak for lumbar or thoracolumbar curve that is the main curve. If the answer of the third question is yes, we go to the plus types. So 3C plus, 4C plus, non-3-4 plus, SLSTL plus. If the answer is no, we go to 3C minus, 4C minus, non-3-4 minus, SLSTL minus. So in total, we have 8 types of scoliosis. Here is another slide that I can present it to you. There is a lot of photos of the patients for each classification in standing and also bending. In every type that there are 2 different types, plus or minus. In plus type, overcorrection of the main curve in some or in all exercises. In minus type, no overcorrection for any exercise. With S type, we speak about structural proximal thoracic scoliosis with apex, T5, and above. Also, in our classification, we have kyphosis type. We describe kyphosis type, thoracic kyphosis, thoracolumbar kyphosis, and also lumbar kyphosis. Here's another slide that represents very well our classification, and also that down in the page, we have also the X-ray of each of them. Definition of overcorrection. Some of them would ask, what is overcorrection? I could not go more in depth because it will take a long time to go in depth for overcorrection. Overcorrection is the maximum correction for the main curve. We have overcorrection techniques that could use in some curve types, also overcorrective exercise. For example, in 3C plus, we use overcorrection for the main curve in every or in majority of exercise. Also, we could use some overcorrection techniques if we have 3C plus with minor lumbar, or non-3-4 plus with minor lumbar, and 4C plus with minor thoracic, and that's SLSTL plus. Overcorrection is not allowed in minus type. Now I want to say to you how we decide to overcorrect or to not overcorrect. We take some, let's say, data that are clinical criteria, radiological criteria, and prognostic criteria. What we do, we analyze all these data, we synthesize these data, and we decide to overcorrect or to not overcorrect. Here are some results of treating with PSSC Schoff method and also with a brace. This is a young girl treating for 1 year with PSSC Schoff method and also brace. Here's another nice example of a nice correction in brace, and also in 6 months we got, let's say, almost 10 degree in lumbar and also 5 degree in thoracic. Also, here's another patient that it is treating with PSSC Schoff method and also exercise, so we avoid surgery. And this is a nice example of how you can help these patients with recommending the, let's say, the brace, and also recommending the specific exercises to them. This is another slide that I would like to spend a little bit more time. I want to thank all my departments, and also I would like to thank especially Dr. Manushachi Sarachi, that is the director of our department, and Perli Russi, that is also the head of physiotherapy department, and also my colleagues that I want to mention one by one, with Elton, Eddie, Eri, Andy, Blerim, Ola, Angela, Lulieta, Platon. I hope I have not forgotten all of them. And I would like also to mention the PSSC Schoff instructor, that I want to thank all of my colleagues that's spreading the PSSC Schoff method around the world, with Dariusz Czaprowski and Lukas Stolicki from Poland, Yakutia Vuz, Merve Karatel, and Durshin Serintur from Turkey, Gorgiana Koyatsaru and Larisa Jakob from Romania, Sara Moed Ali from Egypt, Alexander Perpun from Russia, Marie-Louise Smith and Gabriela Kaczanski from Netherlands, and Firas Vabde from Syria. PSSC Schoff education is going also in all the countries that you are watching, and giving the lecture and also the seminar in all these countries. And soon they will be in China, USA, South Africa, Canada, Brazil, Australia, and etc. etc. We have a lot of things to do, and I want to thank all of you, and it was my pleasure to be here with you, with all these wonderful panelists and also wonderful participants. Thanks a lot.
Faleminderit Silvio, faleminderit për temën të cilën trajtove. Duke qenë se kemi ecur goxha me kohën, tani do t'i lëm disa minuta, 10 minuta për afërsisht deri në 15, për çdo që mund të ketë pyetje për folsat e webinarit të sotshëm. Nëse doni, përdorimi i chatit është mundësi shumë e mirë që të mund të shkruani pyetjet tuaja në chat, edhe ndërkohë edhe Silvio besoj mund të më ndihmoj me pjesën e transmetimit të pyetjeve tek folsat.
For everyone who wants to ask all the panelists, feel free to ask all of them your question. You can use the chat of the Zoom meeting. So if you want to ask anything about all the topic that we discussed, so feel free to do it.
Ju nxis realisht që të bëni pyetjen tuaj, ta shfrytëzoni këtë mundësi, meqense kemi një panel ekspertësh, dhe të bëni pyetje konkrete që juve i keni në mendjen tuaj, në praktikën tuaj të përditshme me pacientët, pra pyetje vërtet që do t'ju hyjë në punë pa u stepur, se e dim që kultura shqiptare ka pak stepje kur vjen puna te bërja e pyetjeve. Por që realisht të nxis, ta shfrytëzoni mundësinë e sotshme. Ose nëse ka diçka të paqartë nga slajdet, ndoshta ka që ka qenë në anglisht një pjesë edhe nuk e keni kuptuar qartë. Okay.
May I translate it for the panelists?
Oh, yes.
The first question is for every panelist. How can if the patient is suspected for scoliosis, where can I refer? This is the question for Darius, Sabrina, and also Dr. Rafa.
Silvia, could you say again what is the question?
The question is if the patient is suspected with scoliosis, where can I refer first?
So if I can start,
yes.
I am not sure what does it mean suspect. So
they are not sure. The family is not sure about if it is scoliosis or no.
Okay, so I would recommend to go to the physician or trained physiotherapist and to make the simple evaluation using scoliometer. So if the angle of trunk rotation, how I presented in my speech, is 7 degrees, and we see lateral curvature of the spine, I think that it is good to extend diagnostics, maybe with X-ray. Of course, we have to decide individually. But when there is no rotation, so I would recommend observation with 1 year interval, or maybe if is positive family history, joint laxity, for example, or flattening of thoracic kyphosis, maybe the intervals between examinations should be in shorter intervals. That means 3-6 months. And if X-ray will be positive, that means we have scoliosis. We have discussed about starting treatment, probably firstly with physiotherapy, then maybe brace.
Okay, thank you, Darius, for your opinion. Sabrina, can I have your opinion?
Yes, hi everyone, and congratulations for this event.
Thank you.
So I think I strongly agree with what Darius said, and I would say that until scoliosis is just a suspect, probably general practitioners or doctors closer to the patient can manage observation over time. While when there is stronger signs of scoliosis or a clear scoliosis, meaning that we have a patient with significant asymmetries in the trunk, or, for example, a big hump. So in case of significant signs of scoliosis, then they will need an expert for sure. So in many cases, then they need to move generally far away from their home to have a consultation from the expert. But until there is just a suspect, the better should be observation over time by a doctor or an expert, meaning also a physiotherapist able to screen the patient closer to their home.
Thank you so much. Dr. Rafael, can I have your opinion about the first question? Or if you want, I can repeat it for you. Okay. We go to the second question. The second question, which are the, sorry, not the question now, which are the opportunity to integrate artificial intelligence in managing scoliosis? This is the question for all the panelists.
Silvio, you have to a little bit louder because...
Oh, okay. Sorry, I have to translate again. Which are the opportunity to integrate the artificial intelligence in managing scoliosis?
Good question, but I am not sure I am able to answer for that. I have no experience, so sorry.
Okay. I have a comment on this.
Yes.
So, so we like so much artificial intelligence words. It's like hot topic. But to use artificial intelligence, we need data. And currently in the field of scoliosis, we don't have systematic collection of clinical, radiographical, demographic, treatment-specific data. So we can talk about it as much as we can, but until we don't start a systematic collection of data, we will never be able to apply artificial intelligence. There is something on imaging, like trying to use some fixed points on images to automatically determine the Cobb angle or vertebral rotation and other measurement which could be useful. So probably this will be the first result of the application of artificial intelligence, machine learning, and this kind of tools. But this is because they use radiographical machines or images tools that can collect a lot of data and then use artificial intelligence and machine learning to automatically calculate the measurement and evaluating the patient. There is also something on the images of the patient. So starting from the asymmetries, we can pick up from outside and then translating into a risk of or estimation of the Cobb angle. But this is more prone to error than other type of. But in general term, we are probably right now beginning in collecting some data systematically. And it's not in Excel file, it's developing multi-center databases where to collect systematically some certain type of selected data for that purpose. So that will be something which will happen hopefully in the future.
As I've seen, EasyGo Group, they are trying to do some research about that I've seen some of them, but no results until now as far as I've seen them. So it's that we have to see in the future.
Yes, consider that artificial intelligence, if you talk with an engineer, it can be applied to big data. Big data means million. Currently, EasyGo has some thousands data. Then you need to select the type of patient you want. So generally, they have large sample. I mean, like 1,500 or even 3,000, but it's still small for artificial intelligence application.
Let's go to another question. Hi, how can we treat scoliosis that it was developed after the birth or after the pregnancy? And is there any way of preventing?
I didn't hear you well, so
I can repeat again.
Yes, please.
How can I treat the scoliosis developed after the birth or after the pregnancy? Is there any way to prevent?
Okay, so in what I suggest to my patients, so ideally when they finish growth, depending on the cobangle and related to the natural history, I recommend a follow-up over time, which could be, for example, in a milder curve around 20 cup degrees, a visit every 5 years, between 30 and 40 every 2 years, and more than 40, 50 cup degrees, I recommend a visit every year. The X-ray should be taken between 3 and 5 years. Continue monitoring them all over adulthood. This is good because I show you that Weinstein study showed that curves exceeding 50 cup degrees progress on average 1 cup degree per year, but the measurement error at the X-ray is 5. So practically we cannot perceive a change of 1 cobangle, so we will be able to perceive a change of at least 4 or 5 cup degrees. So let's imagine if progression is starting, it will take 5 years to make a doctor aware of what is happening through the X-ray. Then the other wrong interpretation of those data is that in adulthood, we have a progression, consistent progression over time. That is not true, that is false. So in adults, they remain stable for many, many years. And then at a certain point, we don't know why, it could be menopause, it could be an overload of the spine in my experience. So for example, I had patients taking care of husband or other family members for years. So moving the patient and weighting very high loads, and then having a progression, or some years after menopause. These are the major situation that I have seen in my experience. And so when something change, it's in adults, it's the generation that is generating progression. So the degeneration is not happening consistently over time. It has some sort of peaks, like in growth, but we cannot predict when the peak will be. So the only strategy we have is follow-up. This is what I explain to the patient. So please, even though you are well, come back at least every 5 years. In more severe curve, higher risk, better earlier, every 1 year. So in all these patients, if they understand this recommendation, then it's easier, because before pregnancy we have everything, so the measurement, and we are sure that the progression happened after delivery because of hormonal peaks or whatever it is, we don't know, but we can be quite sure that something changed because of the pregnancy and delivery, okay? Otherwise, without a follow-up, we can just guess, but we don't know if the progression happened immediately after brace discharge, but they become aware of that after delivery or during pregnancy or whatever. So the best is this scenario. That said, in a new patient coming to me during pregnancy with some low back pain, I can suggest some physiotherapy specific exercises to compensate a little bit. And then after delivery, I suggest to take an X-ray, take a visit, and in case we see a progression, we recommend like some 1 year or 9 months of scoliosis specific exercises to compensate, and then starting the follow-up over time.
Thank you, Sabrina. Darius, do you have any opinion?
I think that if we think about infantile scoliosis, the first question is, what is the cause? What is the reason? Is it idiopathic scoliosis? But probably it may be secondary scoliosis. So sometimes the primary problem we have to take into consideration. And Sabrina presented in her presentation the mbeshtetesit angle. It is also important for the evaluation of the risk. So this is my answer.
Thank you, Darius, for your opinion. Another question is that in what age can it's let's say advisable to remove the brace? Is a question from one of the participants.
Okay, I go first.
Yes.
So unfortunately, there is no age recommended. So ideally, so I use this method, which prevented me to ask myself this question ever, because so you start a brace treatment, then you have a goal. Let's imagine you want to correct the spine. Ideally, the goal of the treatment is to end the growth with a curve below 30 degrees. So if we start 30 degrees at research 0 at the beginning of growth, let's imagine 12 years of age. So we need to stop progression and also gain some correction in order to be sure that the progression that we will face during the growth that we are that we have ahead of us, and in the end ensuring, if possible, to end the treatment below 30 cup degrees. With this type of goal, the treatment will start with a full-time brace wear, meaning 21, 22, 23 hours per day of brace wear, if I want to protect my patient from progression and improve the curves. Starting full-time and reducing the time 1-2 hours every 6 months, what will happen is that normally we will arrive around research 3, which is the end of growth, and so the end of the risk period, and is the moment in time where we can start brace weaning. So practically, we do not need to wait an age, but just to slow down the dosage, and practically we will arrive around 18 hours per day, which is part-time, around 3, and then continuing reducing until nighttime. Every 4 to 6 months, we will arrive at the end of the treatment without asking ourselves when is the moment to remove the brace. So this type of questions is asked when you start with a dosage like 20 hours and you keep it fixed until you reach the end of growth. So the answer would be not the age, but reaching regjistrime 3. And I would add having no more than 1 centimeter of growth in height in the past 4 to 6 months. So when the growth is stable, you are quite sure that the growth ended. Only one exception is Marfan syndrome or very, very tall patients. In very tall patients, generally they also have tall parents. Independently, if they are males, most of them are males, but even very tall females, be careful in reducing the time of brace because they have multiple peaks of growth. And so around regjistrime 3, there could be a further last growth peak. It's complex. Sorry for the long answer.
If I can say something,
Yes.
I agree that the research sign is the most important when we want to reduce the time for brace. But my experience is that apart from the research sign, important is cooperation of the child for physiotherapy. If a child doesn't cooperate, in last time I preferred to extend the time of wearing brace to regjistrime 4. Because sometimes I observe that too fast reducing of the time without cooperation of the child to maintaining active self-correction, for example, will lead to the progression. So sometimes I suggest to prolong, to extend the time, especially that children prefer to don't wear a brace at school. It's normal. But the time is from 7 o'clock to sometimes 6 p.m. So finally, a child from 21, 22 hours per day goes to 12 hours. It is too big jump because from 2021, should be 16 hours per day. And then night brace. So because usually I know the child during treatment, and when the cooperation is not on the high level with parents, with children, with child, I prefer to extend wearing a brace since regjistrime 4.
I would like also to know the opinion of Rafa, because he is also an orthotist and he could give us also his opinion about the removing of the brace, in what age he could recommend, or his opinion about the removing of the brace in patients with scoliosis. So I think I hope he's online with us. I hope he's not leaving us before we finish.
Yes, I am here, Silvio, but
yes.
Could you repeat the question, please?
Yes, one of the questions from the participants was that in what age do you refer to remove the brace? Or in what period of do you recommend to remove the brace?
Well, this is sometimes is crazy, because there is people that they start to remove the brace when they are at regjistrime 5, but I had some experiences in the past. I remember perfectly one case that we start with 45 degrees. During the years, we was controlling. When the girls arrived to regjistrime 5, we was at, I don't remember, 18, 19 degrees. It was very good. But we removed the brace with a regjistrime 5, but in 3 months, the curves grow till 38 degrees. And we again need to make a corset like this. So in this case, if, for example, the acceptance of the patient is okay, I would like to continue the treatment to avoid this crazy things. You understand what I mean?
I understand you very well. So is for you, it's better to, let's say, about when you speak about Sander scales.
Exactly. In all of the cases, we need to wait the reaction of the patients. No, if we have a patient that they have no problem to continue it for 6 months with the corset, I prefer. The problem is when one of the multidisciplinary team start to talk to them that probably we will remove the corset. This is the worst case. Because when the girl hear that exists the possibility to stop the treatment with the corset, the things change completely.
Thank you.
You're welcome.
Now it's your turn. So
Thank you so much. Thank you so much to all the panelists. Unfortunately, we have reached our time limit for today's webinar. Ju kërkoj ndjes për ata persona që kanë bërë pyetje dhe nuk kemi kohë që të mund t'i përgjigjemi këtë herë. Shpresoj që të ketë qenë sa më i vlefshëm ky webinar për të gjithë juve. Unë dua të falenderoj të gjithë ekspertët dhe panelistët që ishin sot me ne, doktoreshe Edlira Boden, zonjën Blerina Duka, doktoreshe Mirazi Qishti, doktoresh Sabrina Donzeli, Rafael Hervas, Darius Czaprovski, Silvio Selfo dhe Perli Rusi si një nga kontributorët për realizimin e këtij webinarit të sotshëm, nëse nuk kam harruar dikë tjetër. Për sa i përket certifikatës, do të mund ta merrni në platformën e Urdhrit të Infermierit. Ju lutem, kush nuk është i antarësuar të mund të antarësohet tek platforma UISH. E keni në website-in e faqes edhe kudo, kemi disa muaj që vazhdimisht bëjmë thirrje profesionistët të mund të antarësohen aty, dhe në kategorinë edukimi në vazhdim, ju do të mund të shkarkoni certifikatën e pjesëmarrjes pas disa ditësh, ndoshta nga mesi i javës tjetër. I want to thank all of you for being here today. Thank you for answering the questions and for your support for the Albanian physiotherapists. Looking forward to future collaborations together.
Thank you very
may I
much.
say something, Brenda, May?
Yes.
Okay, I want to thank all the participants that was in this webinar. It was for the first time organizing this thing in Albania, and it was my pleasure together with my with such experts like all of you, like Dr. Sabrina Donzeli, like Dr. PhD and Associated Professor Darius Czaprovski from Poland, and also orthosis and Dr. Rafael Hervas. I want to thank you from the bottom of my heart. It was my pleasure to be in the same panel with you.
Thank you so much to all of you, and congratulations for this great event. From this point, it would be great to keep in touch with you in case you would like to collaborate with me. So thank you so much. I appreciate your invitation, and all the best.
Thanks a lot, Dr. Rafa.
Thank you very much. It was really, really nice to be here, and I hope you found my presentation interesting for you. I repeat only, if you want full paper of the recommendation, please write me, or maybe to organizers, and I will send you to you. Thank you very much again.
It was one of the, let's say that it was one of the highest numbers that we have had in webinar. It was 221 applications for this webinar. So I'm always thankful to all of you guys.
Thank you for inviting me.
I would like to support a message on the chat by Sabrina. So we wait for you in Croatia next year on SOSOC meeting.
Yes, in Dubrovnik,
Yeah,
end of April next year.
Yeah.
Great.
Thank you very much.
It's close to Albania, so I will be there.
Great. See you there. So
bye. Thank you.
I wish you all the best.
Thank you.
Faleminderit të gjithëve, suksese në punën tuaj edhe gjithë të mirat. Qëndrojmë në kontakt për vazhdimsinë.
Faleminderit.